Hi, everybody. It's Susie with Adaptive Mobility Services. I am an occupational therapist and certified driver rehabilitation specialist. My company is called Adaptive Mobility Services. And this is another episode of You Ask, We Answer, all things related to occupational therapy and driving. My goal in these short little recordings is to help answer your questions and provide you with insight and information on kind of how to continue your own journey and clinical reasoning and problem solving. As always, I will offer you my best advice based on my current clinical experience and current evidence available, but I encourage you to do your own research and your own problem solving to find your answers and when work through kind of what's best for your scenario. So today's question actually came from Gabby, who works with me, and I think this is a really great question. It's geared more towards the driver rehabilitation specialist, but I think that it has applications for the OT in primary practice as well. So Gabby is working with an individual who is referred to us from a memory clinic and has a diagnosis of mild cognitive impairment, which can be tough because depending on the type of mild cognitive impairment, we may be looking at pre-Alzheimer's disease. Oftentimes, we are being referred for the driving evaluation. This clinic will refer them to us as they are continuing with their testing to determine if it has Alzheimer's disease through the different spinal cord, the amyloid testing, and so on and so forth. Other times we get mild cognitive impairment that's undifferentiated or is not consistently indicative of something more specific or more specific type of dementia like Alzheimer's disease. So we really have our hands full. We'd love to work with patients who are kind of in this category because they can present so uniquely, right? Each person can be so different. So with that in mind, Gabby actually saw this individual, and I don't have the clinical testing in front of me to share with you, but during the on the road portion, she shared that while this person basically had a baseline of safe driving behaviors or, probably overlearned safe driving skills that they've had their entire life, the big problem for the on-road portion of the assessment was working memory. In fact, she wrote down that let me come right over to it. The big concern was memory. He did not know where he was driving. At times he was driving aimlessly, and he kept questioning where he was going and what they were doing. And so based on this and his diagnosis, Gabby is discussing with the doctor consideration for driving retirement. And as she's completing her documentation, what she's finding is in our documentation, we have a chart of different performance skills and things considered for an on-road assessment. And we kind of indicate with those, so and it includes things like ability to turn on the vehicle, operate the different controls, management of speed, braking distance, lane positioning, right turns, left turns, merges, so different kind of maneuvers. And we'll rate each of those as either intact, marginally impaired, or significantly impaired. And I use that rating scale. We started using that several years ago based on recommendation from Dr. Barco's work out of the University of St. Louis. Okay, so what she's noticing is in the chart, a lot of his driving performance is grossly intact, but she's really recommending driving retirement because of these concerns with his working memory, his awareness of where he was and what he was doing. And so she kind of she sent me an email kind of asking this question, how's it going to look if his chart indicates a lot of factors are intact, but the reality is she has levels of a concern. And I think that can happen for us, right? In the world of driving rehab. It also can happen for us at times when we're doing clinical tests and measures in the clinic or outpatient setting or inpatient setting, but the overall outcome and performance is of concern. And so my best recommendation in this scenario is to address it head on. The first thing I also challenge Gabby to think about is really as he was getting turned around or lost or confused or driving aimlessly, did she notice any small changes, any changes in his pacing? Was he slowing down a bit in the flow of traffic? Was he beginning to interrupt the flow of traffic? Were his decisions a little bit slower? Was he slowing down on his turns or initiations of turns or lane changes or movement into turning lanes? So kind of getting a little critical there. I also feel like one of the areas on our chart is defensive driving strategies. And so we could address and kind of talk about our concerns in that part of the chart as well. But if the reality is he continued to drive very well despite these memory impairments, but we're concerned about the extent of the memory impairments and him truly, as she put, driving aimlessly, not knowing where he was at times or what they were doing, I think that's enough concern with this condition to warrant the discussion of driving retirement. So my recommendation to her is that she address it head on in her summary. And that happens at times where our clinical tests say one thing, but the outcome performance is something, and so we're recommending something different. In that scenario, I think we should address it head on. And so what I said to her was, you might put, that while the majority of the baseline driving behaviors are closely intact, this individual presents with great concern due to changes in working memory. That's also supported by clinical testing in these tests and measures, et cetera, et cetera. But specifically, during the on-road assessment, this individual at times did not know where he was going, was driving aimlessly, and kept questioning where he was going and what we were doing. And while he demonstrated intact driving skills, which were probably an overlearned activity at that point, the level of concern from cognition needs to be addressed. And that his getting lost and not knowing where he was is of significant concern and indicates changes due to his medical condition that signal the need to consider and discuss driving retirement with the referring physician. In addition, these memory changes indicate this individual should likely not be alone in the community. Being alone could increase his risk of getting lost and turned around, as well as his risk of being taken advantage of and placed in unsafe situations. So we would recommend discussing driving retirement with the referring physician, the referring neurologist, and replacing transportation needs with a trusted individual. So not just doing a shared ride, but working with an individual who could work with him and support him. Now, this recommendation really kind of leans on the idea that when we're talking about driving retirement, that driving retirement should include discussion of more than one professional, should be based on more than one observation, and should be made over more than one day, which is something I've really been leaning into over the past year. Fortunately, this memory clinic is a wonderful partner, and so we'll be able to take this information and refer back to them to have a discussion and find out what the doctor really wants to do. Now, it's kind of like an x-ray, right? Like if you go and you get an x-ray for a fracture in your arm, the x-ray tech can basically, or the radiologist can look at the x-ray and say, yeah, that's broken, but we still need the physician to agree and kind of come up with the plan of care. So the majority of the time, the physician will look at our recommendations in our report, and if it aligns, follow up and agree with our recommendation for the plan of care. But it allows for this kind of conversation and engagement of the physician, I think is important for the collaboration and to ensure that we're looking at every angle when it comes to something as important as driving retirement. So big picture with this one, what do you do when really the driving kind of looked okay, but we have other factors that are indicating a level of concern? I say address it head on. I do the same thing if I have somebody who maybe struggled on trails making test for B, but then in the car did really well. I'll talk about how the performance on the paper pencil test says one thing, but that I have conflicting evidence and I can demonstrate a pattern of it being intact in the vehicle by completion of seamlessly completing lane changes, merges in high traffic, decisions at complex intersections, so on and so forth. So I like to, in these situations, directly address it and then use my evidence and examples to create a pattern for the physician to consider. I hope this is helpful. And Gabby, I thank you for your question. You guys, I'm really open to your thoughts and opinions on this. So if you have other considerations, other ways you would address it, please feel free to comment and let me know. And as always, thank you for what you're doing. as occupational therapy practitioners, when we address driving, one of the most complicated occupations, IADLs, I really think that we help to address big goals for people. And that by thinking about something big like this, we're able to facilitate really supportive environments and wonderful change. Even if we're talking about driving retirement, we're able to support this family in a situation where the individual is probably transitioning before something happens where they get lost or turned around or really, something really unfortunate happens, right? Which is what we want to prevent. Especially with cognitive conditions, our job is to identify the changes that are signaling something is changing and help make that transition before something unfortunate happens, right? Or something unsafe happens. Thank you for what you do. OT superheroes, you guys are the best. And keep those questions coming to me. You can shoot me questions at susie@adaptmobility.com or via Facebook Messenger or on Instagram. Really lovely to see you guys and take care. I'm here if I can help.